Good morning, everyone. Today we'll discuss about drug-resistant epilepsy. I am Dr. Bhupendra Shah, doing clinical fellow in neuroscience at Green International Hospital. So the flow of the talk of the today's presentation will be, I'll be defining what is drug-resistant epilepsy, what are the risk factors of drug-resistant epilepsy, what are the pathogenesis and its impact. Then in the last, I'll be discussing on the evaluation and the management of the drug-resistant epilepsy. So there was a study published by Nguyen et al. At NEGM in 2011. We showed that in any patient with the epilepsy, if we give a first drug, then there will be the remission of the seizure in 49% of those patients. And among the non-responder, if we add the second drug, then additional 30%, 13% will respond to the second drug, and only the 4% will respond to the third drug. Mean that there are minimal chance of responding to the medical therapy if the patient do not respond to the combination therapy of the two drugs. That's why the International League Against Epilepsy have defined drug-resistant epilepsy as failure of two appropriately chosen drug with maximal dose to achieve the seizure control with the drug-resistant epilepsy. Here we should remember the drug should be appropriately chosen and it should be the maximal dose. Sometimes because of the misdiagnosis, like the focal seizure is being treated with the broad spectrum antiepileptics, and the generalized tonic-clonic seizure is being treated with the narrow spectrum antiepileptics. That is not appropriate. So the drug should be appropriate and it should be maximal. Even with that conditions, if the patient is not responding, then that's called the drug-resistant epilepsy. So there are multiple research work on evaluating the risk factors for the drug-resistant epilepsy. So as I have already mentioned you, if someone is not responding to the first drug, that is the risk factors for development of the drug-resistant epilepsy. If someone is having the high number of the seizure, then that's also the risk factor for drug-resistant epilepsy. If you do not know the exact cause of the epilepsy, and if the epilepsy is associated with different pediatric epilepsy syndrome like Rasmussen encephalitis or Lennox-Gastaut syndrome or infantile epileptic encephalopathy, then it have more chance to develop the drug-resistant epilepsy. There are some lesions like mesial temporal lobe sclerosis and cortical degeneracy, which is notorious for the drug-resistant epilepsy. And positive family history and abnormal EEG pattern is also the risk factors for the drug-resistant epilepsy. So there is one systematic review done by Kailani et al. Where they have evaluated the near about 13,080 epilepsy patients, out of which around near about 13,941 patients with drug-resistant epilepsy. You can see that near about 30% of our patients with epilepsy may ultimately turn to the drug-resistant epilepsy. And they've also analyzed the risk factors for the drug-resistant epilepsy and the earlier age of onset, symptomatic epilepsy, abnormal neuroimaging findings, abnormal EEG finding, history of mental retardation, neuropsychiatric disorders, febrile seizure, status epilepticus. These conditions have more risks to develop the drug-resistant epilepsy later on. So the pathogenesis, I have taken this chart from the article published by Tang et al. In the Frontiers Neurology, where they have shown that the drug-resistant epilepsy has so many hypotheses like pharmacokinetic hypothesis, gene variant hypothesis, target hypothesis, transporter hypothesis, intrinsic severity hypothesis, and the neuronal network hypothesis. This pharmacokinetic hypothesis is that like when someone is having the drug resistant epilepsy, then the anti-epileptic drugs which we are giving may not be adequately absorbed and may not be entered into the target site in some of the patient, and those patients are more prone for the drug resistant epilepsy. Okay, and so what will the impact of drug resistant epilepsy? Why we need to know about the drug resistant epilepsy? In our day-to-day neurology OPD, we see if someone is drug resistant epilepsy, and if we are adding more and more drugs to control the seizure, then definitely there will be more adverse effect of the anti-seizure drugs. Okay, so they are more prone for the more side effects. They may have more cognitive problems. They may have the educational and vocational problems. They might be having the mood and personality changes. Their quality of life may be restricted, and they have more chance for the sudden death, and as well as there is more chance for the persistent seizure. So you can see the impact of drug resistant epilepsy is very, very huge on the patient who are suffering from these conditions. That's why we need to evaluate this condition properly and manage properly. So differential diagnosis. So we see lots of cases of drug resistant epilepsy. See, one of the important drug cause for the drug resistant epilepsy, incorrect diagnosis. Sometimes psychogenic non-epileptic seizure are being diagnosed as epilepsy, and we are giving the drugs, anti-epileptic drugs. But that's not going to control the seizure in that condition. Yes, and sometimes there are some like sleep related movement disorders, or like sometimes chorea or sometimes athetosis are being treated as epilepsies. If we diagnose incorrectly, then there is minimal chance that the patient is going to respond to our anti-epileptic drugs. And sometimes inappropriate dose, like if you are giving the very, very low doses, then that may not be sufficient to control the drugs. Another important problems in a patient with epilepsy is non-compliance, because they think that, oh, their epilepsy is well controlled, then why you need to take. So there is non-compliance is a very, very big problem in a patient with epilepsy. So this may result the drug resistant epilepsy. And different lifestyle factors like the consumption of alcohol and stress, it can cause drug resistant epilepsy. And there is like psychogenic non-epileptic seizures are being treated as epilepsy, and it seems it is a drug resistant epilepsy. So we have to rule out all these things before labeling someone is having the drug resistant epilepsy. Okay, so how to evaluate? So the number one evaluation is the, if there is a then first of all we have to refer this patient to the appropriate epilepsy center where there is a facility of the video EEG. Video is the combination of the video and the EEG monitoring. So why you need to say when you are looking after the patients, and when you are looking after the video, we can see different movements and the corresponding EEG changes that help us in seizure classification. Sometimes focal seizure with generalized is labeled as this GTCS seizure. So if we have a video and EEG monitoring, then we can exactly classify the seizure type, and even the psychogenic non-epileptic seizure can be diagnosed if we are doing the video EEG. Second important is the MRI, because MRI should be done with the epilepsy protocol. Because if you are doing the MRI with the simple MRI or MRI with less than 1.5 Tesla, we may miss the different lesion. Like in this condition, you can see here there is the sclerosis over here, bilateral sclerosis over here. This is the mesial temporal lobe sclerosis. And sometimes cortical dysgenesis or focal cortical dysplasia or small cerebral neoplasm can be missed if we do not do the MRI with the epilepsy protocol. That's why we have to do the MRI in a suspected case of epilepsy with MRI with epilepsy protocol, okay, to diagnose these conditions as well. And another thing is we have to always counsel our patient to maintain the seizure diary, because where they will write the dietary pattern, timing of medication, then the quality of sleep, alcohol intake, and menstrual cycle. So we know what is the precipitating factors for the seizure. Okay, so seizure diary is must. So the treatment part, there are other treatment modalities as well. We'll be discussing in the upcoming presentations. The treatment part is the first of all the anti-seizure medication. Usually, we do not recommend you to give the anti-seizure medications But there are some conditions like in patients who are not candidate for the seizure surgery, or sometimes, like as I have already told, sometimes we have to revise the anti-seizure medication based on the particular seizure type. In that conditions, anti-seizure medication can be tried. But the result, if we had already used the appropriate drug in the appropriate dose, then the addition of the new anti-epileptic drug is not going to impact the patient seizure remission in the long run. So the treatment for the drug-resistant epilepsy is the most of the time there is epilepsy surgery. The epilepsy surgery is best if there is intractable focal epilepsy, if there is a non-unilateral focus without significant medical and psychiatric comorbidities, and if there is a surgical accessible epileptic zone, then it's very good candidate for the epilepsy surgery. And the surgery that we can perform are the resective surgery, lobar resection, hemispherectomy, corpus callosotomy, and multiple subpile transections. So there are some misconceptions about the epilepsy, like given by the Vakari et al., where he have written number one misconception: all drugs need to be tried. So we need not to try all the drugs because there is very, very minimal chance after the second drug. Okay, so we have to refer the patient to the appropriate epilepsy centers. Second is bilateral EEG spikes are contraindication to surgery. It seems, but even there is a bilateral EEG spikes, there can be the unilateral seizure at onset. Okay, so we have to evaluate that properly. Normal MRI is a contraindication is surgery, definitely not. Even with the normal MRI, there we can detect the single epileptic zone by doing the different test. So normal MRI is not a contraindications for the surgery. Similarly, multiple or diffuse lesion are a contraindication surgery. These are the myths. Surgery is not possible if eloquent cortex is involved. That is also the misconception. We can perform by doing the proper evaluation with in the proper facilities. Okay, so this is study done by Devedi R. et al., where he have shown the seizure-free in a patient with drug-resistant epilepsy after doing the surgery. In the medical therapy, there is minimal chance for the seizure-free period, but in a surgery group, there is a very, very high chance to have the seizure-free survival. Okay, so it's very good. The seizure-free survival is 36.7% surgery group and 0 in the medical therapy group. That's why we should always counsel the patient for undergoing the epilepsy surgery if they are having the drug-resistant epilepsy. Other treatment modalities is sometimes like surgery may be difficult. So in that context, we can go for the vagus nerve stimulation. It's usually for the drug-resistant focal seizure. It's usually for those conditions where there is a multiple types of the seizure, like in case of Lennox-Gastaut syndrome. There are some complication of these conditions, vagus nerve stimulation, like there can be dysesthesia or vocal cord paralysis or hoarseness of voice if you do the vagus nerve stimulations. Cortical stimulation can be possible. It is approved by the FDA in 2013. It's basically for if there's a focal seizure with multiple focus where with the resection is not possible. In that context, we can try for the cortical stimulation therapy. And deep beam stimulation is for the thalamic stimulation we can do, and it's approved by the FDA in 2018. So in the last, there is a concept called ketogenic diet for the drug-resistant epilepsy. Ketogenic diet is a condition where there is a high amount of fat and low amount of carbohydrate and protein. It's been tried in the children with drug-resistant epilepsy and has shown to be effective in those conditions. But there is limited evidence whether it's effective or not in the adult populations. So ketogenic diet is one of the treatment options for the drug-resistant epilepsy. The take-home message is the failure of two appropriately chosen drug with appropriately chosen drug in appropriate dose to achieve a seizure remission is the drug-resistant epilepsy. Before relieving someone is having the drug-resistant epilepsy, we need to assess the correctness of our diagnosis, treatment modalities, and compliance. Okay, and epilepsy surgery is effective in to manage the drug-resistant epilepsy, though it is underutilized treatment modality for management of drug-resistant epilepsy. Thank you so much for your kind attention.